Hello and a very warm welcome. I think we're on. I think we had a few technical hitches, but I think we are actually here, and thank you so much for your patience. A very, very warm welcome. I'm out of breath because we've had technical hitches. And I'm also out of breath because I hear, you won't believe how many people have signed up to this event. We have over 900 people who've registered to attend this event. So an absolutely warm welcome to all of you. This is our official launch event for the Maternal Mental Health in a Pandemic report. And it's a bittersweet day. It's bitter because of the year we've all been through. It's bitter because, as you'll have seen and will hear, this report makes difficult but essential reading. It's bitter because we're not all together, but it's a sweet day because we're bearing witness to what is going on behind closed doors across the UK. And it's a sweet day because I can see from the attendance list, the maternal mental health community all across the UK has signed up, and we are together here today, and we can together do something, more than something, to amplify this report's findings, get the recommendations out there. So thank you. I think we have Luciana on the screen and we have Sarah from the Centre for Mental Health on the screen. You're going to hear from both these people later on in the session. We've got quite a packed session for you. Luciana Berger is Chair of the Maternal Mental Health Alliance. Sarah Hughes is CEO of the Centre for Mental Health, and I am CEO for Maternal Mental Health Alliance. And this event today is a jointly organised event between MMHA, the Maternal Mental Health Alliance, and the Centre for Mental Health. So before I hand over to Luciana, and we've got a little something for you to watch before I do that, a few bits of housekeeping. It's a big attendee list, as I've said. We've got all our, well, I haven't, but you've got your cameras and microphones off. Because of that, we are recording the event today so that we hope to use this to amplify the messages further after this event. Thank you for all questions submitted when you registered for this event. Clearly, we can't get through all of them in detail today, but what we've done is we've taken themes from those questions submitted. There will be an opportunity to hear an expert panel digest some of those themes, those questions. And what you will have today is, you'll see on your screen a question and answer function. Any burning questions, anything that arises during this session, put your questions in there. We probably won't get to all of them, clearly, but again, we will take the themes after today's event and we will write up responses and we will share those on the MMHA website. So there is a way for you to have a dialogue and get your questions answered. We have the hashtag running today, maternal pandemic. So do join the conversation and do feel free to share anything that arises in this session. We have just over an hour together, and during that time, you will also hear from women, dads, mums with direct lived experience of maternal mental health problems with a twist. Yeah, so it wouldn't be the MMHA if we didn't have lived experience running through the heart of it. But we've taken the decision, because we're all going through the pandemic still, sadly, that we are not putting women forward who have had a baby during this pandemic to share their story, because we think that's potentially too raw and we wouldn't be able to support them in that process. What we have been able to do is collect together testimony from women to share their experience with a pandemic insight. And you'll see what I mean more when you see the films. And they're really unbiased, they're very compelling. If anybody feels that they may be unsettled by watching some of this, hearing some of the testimony, and I know we have many mums in the audience today with lived experience, the beauty of this being a virtual environment is just turn your volume down. You'll see when the video finishes, and then you can put it back on again. And I think, without any further ado, just to say, go forth and multiply this report. You're in very safe hands with Luciana. We thank you so much for attending, and I'm going to hand over to Catherine, a representative from Action on Postpartum Psychosis, who will open powerfully with a lived experience testimony.
Hello, I'm Catherine Cho. When my son was 3 months old, I started seeing devils in his eyes. It was the beginning of my experience with postpartum psychosis. By the time my husband took me to the hospital, I was stripping off my clothes and attacking the nurses. I thought that I was a character in Dante's Inferno and that my life was a simulation. I was sectioned in a general psychiatric hospital where I spent 12 days away from my son. After psychosis, I would fall into a clinical depression, and it would be many months before I could hold my son without pain. I look back on those months and I recognize the darkness there, that feeling of hopelessness. I tried to find comfort in the stories of others, particularly from other women in action on postpartum psychosis. Postpartum psychosis is such a devastating event. Even with a happy ending like mine, there are lasting echoes. I eventually wrote a memoir about my experience called Inferno, which was published last year. I wanted to trace the roots of this experience, particularly as a Korean American living in London. I wanted to show that it's something that could happen to anyone. I found out I was pregnant with my second child, a daughter, a week before the first lockdown. I knew that I was at high risk of psychosis during the height of the pandemic, but I felt lucky. Because of my history, I was allowed to have my partner stay with me, and I had great support in keeping the experience as calm as possible, and so I have remained well. However, I know that for many mothers during this pandemic, having a baby has not been a calm experience, and the isolation and fear has been magnified. Women have battled illness and recovery without the support of wider families and communities, and essential frontline professionals have been redeployed, and services stretched to breaking point. It's why this report feels so necessary. These past few months, I have thought about what would have happened to me if I had had my psychosis during this lockdown. And I don't know what would have happened to me or to my baby. I'm so grateful to you who work in maternal mental health, in the NHS, in the third sector, in research, policymaking, and campaigning. Thank you for all that you do to protect the safety and well-being of new mothers and families. As a society, we must prioritize motherhood and fatherhood, and services to support those who unexpectedly find themselves in the most challenging of circumstances. For me, every medical professional we met, every kind gesture, every kind word, I've never forgotten their care. I know that they saved my life. Thank you.
Thank you so much to Catherine for sharing your story with us today. I think your experience really reminds us all why we're here and why the report we're going to be discussing is so vital. I think it would be helpful just to share with you just a little bit about why the report was commissioned. It's been so clear that the pandemic has had a massive impact and a profound effect on all of our lives, but in particular for new and expectant mums and their families. The Maternal Mental Health Alliance and the Centre for Mental Health were growing increasingly concerned about the potential impact of the pandemic on maternal mental health and on the services supporting mental health in the perinatal period. With very special thanks to Comic Relief and their special COVID recovery funding, the Maternal Mental Health Alliance have been able to commission the Centre for Mental Health to do a rapid review of all the available evidence, to identify the learnings from the front line, and most importantly, to bear witness to the experience of women, babies, and families during the pandemic across the 4 nations of the UK. While the report has rightly shined a spotlight on a number of challenges that have come from the pandemic, it's also important to remember that it's not all been bad news, and for some women and families, pregnancy and giving birth during this time has had some positives, with the changes that have been forced on us all, creating silver linings. For example, in some cases, more times for dads and partners to be around and a slower pace of life. We know, though, that even in normal times, more than 1 in 10 women will experience mental health problems in pregnancy and/or in the first year following the birth of their child. And as we're about to hear, the findings of this report show that for many women and families, the virus, the changes in how care has been delivered, and the accompanying pressures, including for health workers, has meant it has been and still is an additionally challenging time to be having a baby, with increased risks for maternal mental health. It's now my pleasure to introduce 2 of the research team who are going to be presenting details and their findings to us. I'm going to hand over now to Rachel Papworth and Graham Durkin.
Hi, Rachel. Rachel's on first, so just waiting for her to unmute. And if our slides could go up.
There we go. Hello, everybody. So I am going to begin. I'm Rachel Papworth. I was working with the Centre for Mental Health on this report, undertaking the research, and I'm going to present to you some of the headline findings from the research. And the first thing to say perhaps seems self-evident, but it's worth stating up front. Oh, do you want to start the slides, Joan? Do you want to put the first slide up? I'll just give Jan a minute to do that. I'll start, and hopefully then Jan will get the slides up at the same time. So yes, the first thing to say perhaps seems self-evident, but I think it is worth stating up front that the maternal health of women during the perinatal period has suffered during this pandemic. Women in the perinatal period have been negotiating what would already have been a challenging time of their life during a period of national and international crisis. In addition to their fears about catching the virus, their baby's well-being and that of other family members, plus in many cases worries about job security and the range of practical challenges that we've all been dealing with, they've had all sorts of concerns about how to manage at what would always have been a challenging time in the context of the restrictions and without their normal support being available. Anxieties that have often been compounded by lack of clarity about service provision. Will their partner be able to attend their labour? How will they cope if not? Will their partner be able to visit them and their new baby in hospital? How will they cope without the informal support from family and friends that would normally have been available to them at this time? And if someone does give them face-to-face support, are they breaking the rules? And what if they get caught breaking the rules? How are we doing with the slides? Great. So do you want to just stop there, Jan? We're getting them all at once. I'm just going to keep going. I think the slide's not quite in line with me at the moment, but I'm just going to keep going. So it's been, and it continues to be, a tough time for women in the perinatal period in general. And on top of that, it's now well recognised that the impact of the pandemic and the restrictions is not borne equally, and that groups that have suffered disproportionately include women in general within the pandemic, and people of colour and people experiencing socioeconomic deprivation. And of course, these groups overlap to create what's known as intersectionality. So that's the way that being a member of more than one disadvantaged group doesn't just pile disadvantage on top of disadvantage. The challenges interact and compound each other so that they add up to more than the sum of their parts. Our research identified a considerable list of categories of women in the perinatal period whose mental health has been disproportionately affected by the pandemic and the restrictions. And I'd like to just spend a few minutes drawing our attention to some of those groups. So disparities in mental health and mental health support have widened for women of colour in general and for various ethnic communities, including travellers, refugees and asylum seekers, and women and families where language is a barrier. Women whose family situation presents additional challenges have had those issues compounded by the pandemic and the restrictions. So that includes single parent families, care leavers, women whose relationship with their partner was already under strain, women with a history of experiencing domestic violence, abuse, or coercive control, and women who've lost a pregnancy in the past or who have been recently bereaved. Pregnant women working in high-risk settings have lacked occupational guidance, leaving them uncertain and anxious about whether they should be working. And naturally, women whose access to services was reduced by the restrictions have suffered as a result, and that includes both where the support ceased to operate altogether, and also women who lacked the means to access services that moved to being delivered digitally or who weren't comfortable with digital interaction. And the situation has been particularly challenging for mothers with existing poor mental health or a history of mental health problems, including severe postnatal mental illness. There are significant concerns about the impact of the COVID-19 situation on women with pre-existing mental health conditions. Many professionals prioritised such women for support, including for face-to-face support where and when that was possible, but everybody we spoke to was concerned about this. In addition, unfortunately, the COVID-19 situation has been unfolding on top of existing gaps in perinatal mental health services, with unequal government investment across the 4 nations and cuts to maternity services, health visiting, and community and voluntary services. And of course, it's not just about formal services. The situation has severely restricted social contact for all of us, and the restrictions on social contact have had a huge impact on women in the perinatal period. In normal times, friends and family provide crucial practical and emotional support to women during pregnancy and early parenthood. And this includes both existing friends and family and new friends that they meet through attending groups and meeting others in the same situation. Obviously, the restrictions have massively reduced this type of support for women in the perinatal period. So parents are missing out on the normalization of the natural worries that come with being a new parent. Isolation compounds anxiety that would normally be alleviated through just saying, like, you know, is this normal, to a friend or a relative, or as an aside to a healthcare worker or a third sector support worker. And oh, next point, Jan, you caught up with the slides. And of course, it's not just about apologies, sorry. Yes, so support from partners has also been affected. The pandemic restrictions have prevented many partners from accompanying women to scans and other appointments. It's prevented some of them from attending early labour or induction and visiting their partner and child in hospital in some cases. So that's made things for all women in the perinatal period more difficult, and it's increased stress and anxiety, and it's particularly acute when complications are identified and you don't have your partner with you. Health visitors told us there have been more women reporting traumatic births, and that is often due to their partner not being there or only being present behind a screen. Next point. And we don't know what the impact of all this will be on the babies born during this period. Children born in the last year have just not had the normal amount of contact that they would have with a variety of people normally. So many have not even yet met their grandparents face to face, let alone been held by them or had them involved in their care. And where babies do have face-to-face contact with people other than their parents and siblings, those people are often wearing PPE. And we don't know what the impact of this will be. It's at the very least, it's a source of anxiety for women in the perinatal period. Next point. The government did identify pregnant women and new mothers as vulnerable from early on in the crisis, but unfortunately, this seems to have been seen only in terms of the risk and impact of infection, not the importance of supporting perinatal mental health. And it doesn't seem to have prevented services being reduced. Given the recognised challenges of the perinatal period, we argue in the report that there was a clear rationale for not just maintaining but increasing perinatal support during the pandemic. In this context, people in the perinatal workforce across the public and the community and voluntary sectors have also been facing additional challenges, including additional workloads and changes to their working practice in the context of their own stress and anxiety around the pandemic and the restrictions, and themselves and those close to them becoming ill and perhaps even being bereaved. The community and voluntary sector is also even more concerned about the future than usual, anticipating that there's likely to be less money available in the future. Next point. The restrictions around the pandemic have hugely increased use of digital services and accelerated their take-up. So Zoom is undoubtedly one of the winners in this situation. And there are definitely advantages to digital provision that go beyond infection control. So through this study and other work I've been doing, actually, I've heard many people talk about the way digital access increases accessibility. It removes travel time and costs. It makes it easier for people with social anxiety to interact in some cases. And many organisations are planning to continue digital provision, often alongside reintroducing face-to-face contact in the future. And that's exciting in terms of accessibility. At least one third sector provider I spoke to has permanently expanded from operating locally to operating nationally as a result of moving into digital provision. But we don't yet know how it affects the effectiveness of provision. So how the impact of digitally delivered services compares to those delivered face-to-face. And there are concerns about providers finding it harder to identify vulnerable families when interacting digitally. Plus, it undoubtedly increases exclusion for some people, including those who lack digital access or familiarity, or who have existing communication challenges, whether that be language barriers, or also those who haven't got a safe private space at home to interact from. And even where interacting digitally is an option rather than the only way to engage, this can still have an impact. For example, again, in connection with other research, I've spoken to people with poor mental health who explain that having to attend support groups in person acts as their only impetus to leave their homes. So they've really valued being able to engage digitally, but they've got this worry that if digital continues to be an option as a way to engage, they'll be tempted to go on engaging that way, and then they'll miss out on the benefits they'd have experienced if they've been pushed to interact face-to-face. So we need robust research into the impact of providing services digitally and the effectiveness of digital provision by comparison to face-to-face for different groups of people. Last point. So as Luciana mentioned, some people did find silver linings in the situation. So some benefited from having their partner at home more, or from not having to maintain their house to a high standard and receive a stream of visitors. But overall, what we saw was that perinatal women's need for support increased as a result of the pandemic and the restrictions, but that what happened, at least initially, was that contact with GPs, midwives, health visitors, mental health services, voluntary and community services, and informal support all reduced. Plus, in addition, some women were nervous about attending appointments for fear of infection, or they were reluctant to bother professionals that they perceived as overloaded. Once PPE was in place and virtual services were set up, many, though not all, services returned, but we don't yet know how digital delivery, PPE, and other factors like increased caseloads, reduced continuity of care, and services being provided by less experienced staff as a result of redeployments have impacted the effectiveness of those services. So I'll hand over to Graham now to tell you a little bit about what our recommendations were on the basis of those findings.
Good morning, everyone. I'm Graham Durkin from the Centre for Mental Health. I'll be going through the recommendations, and Jan, if you could just sort of have them come on one at a time and I'll talk to them. Before I talk about those, I thought I'd just share how we got the data. There was 5 data collection activities that we took part in. First was a rapid review of published and unpublished literature, which we were virtually doing right up to the point of printing because there is still information coming in. We conducted a survey within the voluntary sector, particularly to see how providers in the voluntary sector had coped over this period, their experience. We tried to look at all of the national data sets. There'll be a bit more about that in the recommendations in a moment. And the final 2 bits really were responding to a call for evidence. So we got written evidence submitted, people submitted sometimes reports, but often sort of pieces composed especially for this, up to 1,000 words. And then we had 3 evidence-giving events, which Rachel took the lead on, and where people presented live evidence at the time. And we were collecting this data around sort of October time, if I reflect, and we were really reflecting back, particularly on the first lockdown and subsequent restrictions. Okay. So the recommendations follow neatly from everything that Rachel has presented. And the first one is really, we need the departments and ministries responsible for health in all 4 governments across our nations to to assess the level of need out there, maternal mental health needs. One of the reasons for that, as you've heard from Rachel, that a lot of services probably weren't in the best place at the outset of this crisis, at the outset of the pandemic, due to cuts during the years of austerity. And I think what we need to do is, what is the level of need? And we need governments to decide what is the resourcing for that. Recommendation 2, Jan, follows on from that. So once we've established that, there may well be future crises. We don't know how this is going to carry on. We don't know if there's going to be new variants in the next couple of years. We've all got our fingers crossed that this doesn't carry on, but we want to make sure that some of the mistakes we believe made, some of the redeployments at what was a heightened time of risk are not repeated. And so, a commitment to stick with a minimal level of resourcing once we've established what that is. Okay. And recommendation 3 supports all of this. We really do need to have sort of up-to-date data across all 4 nations. England are a bit ahead in this. We've got NHS Digital, which does report on specialist perinatal mental health care and some other aspects of mental health care, but we think that needs improving on as well. But we had real difficulty in getting public live data from the other 3 nations. And that's absolutely critical. And as we know, and as Rachel has emphasized, not everyone was affected equally during this. We were all affected, but some communities were hurt more. People of color, racialized communities were particularly affected, and we need data to pick up on that as well. So that's, we need quite fine data. And the next recommendation really follows on from that. Lots of communities were adversely affected. Lots of groups are more vulnerable, but something that was very prominent in the research was differences for people of colour, for racialised communities, and the difficulties that they face. So we need to understand that better, and we need to sort of link in responses to that to other policy drives at the moment. So advancing mental health, the Advancing Mental Health Equality Strategy, we need to link in with that around maternal mental health care, and the Patient Carer Race Equality framework as well. The next recommendation talks about more research, as will the one after this as well. We don't know exactly what the long-term, medium and long-term effects of this, but we need research that's going to explore that and tell us what's going to happen. We need research that tells us about particular vulnerable communities. So that could be many of the communities that Rachel has talked about, and in particular, women and their families of colour as well, and the impacts of them. But also we need to understand about partner mental well-being, how that affects mothers' mental well-being and vice versa. The next recommendation is all about research. It doesn't seem that you're going to see all of these on screen, so they seem to have dropped down a bit, but don't worry, I'll tell you what this one is. So we talked, we've all made this massive move to remote and virtual platforms, and it's great, it's had some benefits, but I think there's a massive exercise across the 4 nations for the NHS to understand what the benefits are of that. Yes, it can save money, but it can't be at the cost of risk. So I think there's a research project there for the NHS to better understand where and when to use technology and where we should prioritise face-to-face communication. The penultimate recommendation is around the voluntary sector and recognising the role of that group. Now, many voluntary sector services have suffered during the years of austerity, and we know from our survey that demand on them in this past year has gone up dramatically, but many of those services working in the sector have not been able to meet that demand. And I think a lot of that needs to be about addressing funding, short-term initiatives. We need to move on and provide longer-term funding and recognise that the contribution of that sector. And the final recommendation we have is really about thinking about the workforce and their well-being. Again, we've talked about the potential long-term effect on mothers and families of this. Well, we need to think about the long-term effect on staff of this. And we know that staff are exhausted in all health sectors, particularly this. But I think it's also worth bearing in mind that even in normal times, this is a difficult sector to work in. Just taking one example, midwives. One British study estimates that midwives see around 60 traumatic births a year. Their risk of secondary trauma as a result of that is really high, but so too is their risk of PTSD. So I think it's something that all providers across this sector need to address and have plans in place for managing the well-being of their staff. Thank you very much.
Thank you so much, Rachel and Graham, for all your work, everything that you've done on this report and for presenting it to us this morning. To begin to reflect on these very, very important findings, I'm delighted to now be joined by representatives of a selection of frontline professions who provide support for women in the perinatal period. There are, of course, many professional groups that the report refers to and could all be joined and be joining this event to speak here today. But in the time that we have an impressive lineup covering perinatal psychiatry, midwifery, health visiting, and the voluntary and community sector. We're also delighted to be joined by Comic Relief, who have a wealth of experience in funding mental health, and we look forward to hearing their insights too. It's now my privilege to introduce you to the panelists this morning. We have with us Janet File. She's the Professional Policy Advisor at the Royal College of Midwives. We have Dr. Alan Gregoire. He's a consultant perinatal psychiatrist and honorary president of the Maternal Mental Health Alliance. Natalie Nuttall is lead coordinator of the Hearts and Minds Partnership. Melita Walker, mental health lead from the Institute of Health Visiting. And Suella Aksoy from Comic Relief is the funder of this report. As Emily mentioned at the start, we've had a number of questions that have come in and we've sought to group them into themes, and I'm going to go through those. And hopefully, if we've got some time at the end, we'll add some more from the questions that come through on the chat. If I can turn first to you, Alan. Alan, as we've seen from the findings, before COVID-19 hit, support for women and babies in the perinatal period was unequal across the 4 nations of the UK. The report also shows that not all women have been impacted equally. In your view, as a perinatal psychiatrist and as our honorary president of the Maternal Mental Health Alliance, what do you think are the biggest lessons that you are personally taking from this report?
Well, it's surprising, isn't it, that the lessons that we see in this report are very similar to the lessons that I think the whole nation has learned about physical health, and in particular COVID, during this rather long crisis that we've been living through. Firstly, the services for very severe problems are absolutely critically important. And in this context, obviously we learnt that with COVID and physical health, but in this context, it's still the reality across the UK, across the 4 nations of the UK, that the services for perinatal mental health for the women with the most severe illnesses, as the one that we heard about earlier on in the film, are a real postcode lottery. The NHS can build huge Nightingale hospitals when it wants to and put its mind to it, and when politicians decide that's a priority. But for decades, the NHS has been denying women and babies equitable access to evidence-based, NICE recommended, life-saving perinatal mental health care. And I really think it's time for all of us, on behalf of the women who sometimes can't speak for themselves because they're too ill, to say enough is enough. Just as we are hearing on the streets from many women about other issues at the moment. But there is a second lesson which also parallels the COVID experience, which is that we've learned to our cost with COVID that our infrastructure for the less acute, might I say, the less glamorous, the less spotlighted by the media end of services is just as important. And we've learnt that with public health in the NHS, which was absolutely decimated after years and years of cuts. And suddenly we realized we needed it. The private sector completely incapable of stepping in to fill that gap. And it has taken time to build up the fantastic public health systems that we have. Well, we need to invest in those in mental health and maternal mental health in particular. We need universal services, maternity health visiting support, third sector services, which are absolutely critical and do things that statutory services can't do. And of course, we need families and friends to be supported, to value and support women at this time. May I just add a couple more things? I know I've taken up a lot of time, but I think really important from this report as well, the same lesson as with COVID, inequalities across our society are highlighted and amplified. It makes me think that those people who are already living close to the edge of a cliff are going to be the first to fall when we're all pushed and put under pressure. And those who are most vulnerable are going to be those who are most damaged by the fall. And it is about time that our society learnt that, and that our society learnt that it is very often those on whom the future of our society depends and relies. And really a sophisticated, wealthy society like ours really needs to learn those lessons. So lots of really important lessons from this report, but actually in many ways, given the lessons we've learned across the whole of human well-being, none of them hugely surprising. It's just that they definitely apply in perinatal mental health.
Thank you so much, Alan. I think everyone, will echo your call. Enough is enough, and to build on what Emily said at the start, I'd encourage everyone. I'll remind everyone at the end, but please do share this report. Please do amplify it far and wide. Please do use the hashtag maternal pandemic. Please do share it with all your networks, to make sure that we get that message out. If I can ask the second question of Janet, the report talks about specific pressures that have come with giving birth at this time, with some groups of women facing multiple challenges. Can you just share with us a little bit about the difficulties that midwives have experienced supporting women's mental health over the past year? And what strikes you as key if all women are to receive the care that they need going forward?
Thank you very much. I'll just make sure I am on mute. Thank you very much. What is important for midwives is the fact that at the start of the pandemic, we had to quickly pull together and decide how we're going to look after women, what is key. But in doing all that and trying to protect ourselves, we tended to have missed the women who are stuck indoors, the ones who are vulnerable, and they became invisible. But the key for midwives was the fact that they themselves were stressed. The NHS staff survey recently showed that about 55% of midwives reported feeling unwell as a result of work-related stress in the last month, in the last 12 months, in fact, during the pandemic. What happened was we had to quickly try and get women, see women virtually. And the tech glitches and other issues, the fact that we cannot really talk to women one-to-one, ask them what they need and support them like we would normally do, actually placed a lot of stress on midwives. And if you look at the Coronet study that's going to be reported in August, they talked about the fact that although we've gone for a lot of although we've gone for virtual consultation, that study was showing that virtual appointments only benefited certain groups of women, and those who are working from home and those who are receiving continuity of care. But the virtual appointments and the virtual consultations with women were allocated to midwives who were shielding or those who were off sick, so they were not actually au fait with the issue of perinatal mental health and how to assess women. All the informal links that women had and going out to meet friends and and mothers and toddlers groups, women were not able to access that, and midwives were not able to refer women because those groups and those informal meeting places, they disappeared during the pandemic. Another thing that I'd like to actually focus on really is that us as midwives, we're not really big in terms of our knowledge and expertise of mental health issues. And it's not necessarily one of our strengths. And when midwives are particularly short of time, we may not pick up on how much support women are needing and their needs, and we feel that possibly we cannot help, or maybe we don't know where to refer women to. So there's something about our knowledge and awareness alone cannot mend the gaps that have been identified in this report. We need to train midwives specifically to think about the other comorbidities that are associated with perinatal mental health problems. So there's something about our knowledge and the fact that the awareness alone cannot mend the gaps. We need to be trained, and we need to always keep ourselves up to date. If I go back to the specific questions you asked, there were issues about identifying and referring women who have been victims of domestic abuse. So we need to be able to link mental health with comorbidities, such as domestic violence. In the first month of the pandemic, the project, which calls itself Counting Dead Women, identified 19 killings, which they attributed to domestic abuse. So we need to think about perinatal mental health in a much broader context than just relating to the pregnancy alone, and that women who are pregnant are much more at risk of other comorbidities. And the fact that the women who became invisible, we weren't able to help them as much as we could have helped them. And I'm going to go back to what Alan said, and highlighting the fact that we need to up our game in terms of continuity of care, because that went awry. Only if you could articulate what you want and insist that you'll have the same continuity of care would you have it. So in a way, going forward, I think continuity of care for the groups that have been identified in this report as really suffering disproportionately. And there's something as well about translation. Those women whose first language were not English, they also suffered in this pandemic. They also find it very difficult to report mental ill health. So I think we need to continue to campaign. We need to continue to highlight these issues. We need to continue to talk about the fact that it's not only women that suffer from mental ill health. Midwives themselves are at a very high risk because of the work we do and the fact that on many occasions, we find it difficult to change things at the clinical level. So that's why I will stop for now. Thank you very much.
Thank you so much, Janet. You covered so much in your contribution, and people have had that very, very closely. We're now going to be joined on the line just due to some technical challenges, but Melita is with us. Melita, the report shows there was a reduction in service availability, especially at the start of the first lockdown, with health visitors in some areas being redeployed to other services. Where health visiting services remained, those services worked really hard to adapt creatively. They included switching to virtual offers. Can you share with us a little bit about what the impact was of the decision to redeploy some of those services for that whole family unit, especially for those particularly isolated and struggling? And how confident are you that the lessons have been learned to prevent such redeployment if we are ever in a similar situation? And what, in your view, needs to happen going forward?
Okay, thanks. Can you hear me okay?
We can.
Yeah, brilliant. Okay. I'd like to put on record our thanks to the Alliance for undertaking this work and creating a public opportunity for us to come together, to think together about how we are going to meet the increased mental health needs of our families. To answer your question, I think just to provide a bit of context and background, health visitors are qualified nurses or midwives who go on to study at a specialist level in public health to become health visitors, and every family has access to a health visitor, and they are there to support all members of the family to enjoy good health. So good health, health is affected by a multitude of things. So health visitors might be working with families to support a very broad range of need. And those needs, left unsupported, as this report clearly shows, can actually tip families into experiencing mental health problems. Health visitors have a vital role in promoting good mental health, in preventing mental health problems, identifying them early, offering evidence-based intervention, and care coordination and timely referral when more specialist services are needed. I would say that family mental health and wellbeing is the bread and butter of health visiting practice. This report clearly outlines how parents have been struggling with isolation, and lockdown has been particularly difficult for those living in cramped and inadequate housing conditions. And many families have been tipped into vulnerability and poverty. For some families, home has not been a safe place. And as it's already been said, rates of domestic abuse, serious incidences and child maltreatment have all sadly increased. Rates of mental health problems are increased and inequalities are widening. The family-centred holistic role of the health visitor cuts across and can make a difference in all of these areas. Thus, that means it can positively and proactively support good family mental health and wellbeing. That said, as you've highlighted in your report, health visitors can only make a difference if they are in the sufficient numbers with the right capacity. And there is now overwhelming evidence that health visitors in England are now so stretched by the increased levels of need in their huge caseloads, but as a result, they are only actually seeing the tip of the iceberg. Many parents are reporting actually that sadly they haven't seen a health visitor for months. Now, the root cause of this sad state of affairs really isn't a failure of the health visitors, who I must pay tribute to for going above and beyond to support families in the pandemic. It's rather the consequence of years of cuts to the health visiting service, which without redeployment, actually we entered the pandemic in an already much depleted state in England. The other nations are faring a little bit better in respect of their numbers of health visitors. So the perinatal period we accept as a vulnerable time. We know it's a vulnerable time for mental health without a pandemic. And the first 2 years of a child's life are so important. And the
Melita, are you there?
Hello?
I think we might have lost Melita. We'll see if we can get her back, but in the meantime, I'll pass it on to Natalie. Natalie, if I can ask you a question, and thank you so much for being with us and speaking on behalf of the voluntary sector today. The report demonstrates the importance of voluntary and community services and how they too have had to rapidly adapt to virtual offers. It also raises concerns about funding opportunities, particularly once emergency COVID funding has run out. Can you share with us a little bit about the challenges and opportunities that the voluntary and community services sector have found in switching to virtual communication, and what needs to happen to ensure the sector, such as those like your Hearts and Minds partnership represents, what they need to survive and thrive going forwards, and how can this report help you in that endeavour?
Okay, well, thank you so much, firstly, for inviting us to be on the panel. It's such an important report to be sharing today. The partnership is here to connect and support grassroots perinatal mental health services across England, so we'll do our best to speak on their behalf. I'm going to answer your question in two parts, if I may. The first one being how the VCS sector has adapted within the pandemic. And the response to that would be with strength, agility and reliability. A lot of services have transitioned to virtual support and in-person support where permissible, and supported families at scale across the nations. I think Rachel touched on earlier before the pros and cons of using virtual support, so I won't go over those too much, but would also add in addition to it not being equitable, I think there needs to be some concerns raised around potential safeguarding issues relating to virtual support. It's really, really important, as far as we can see, that VCS services are truly embedded within the clinical landscapes in which they operate. Just gives that added layer of protection for services. And then secondly, what does the VCS sector really need to thrive? It's such a significant question for us at the moment, and the report highlights that, which is brilliant. In point 7, it refers to the high demand for services, and we think the reasons for that are multiple. The redeployment of primary care staff, which I know Melita has just touched on, the lack of face-to-face contact within the community, which is so vital for parents in the perinatal period, and also the thresholds for specialist care. The result of this is we're seeing that VCS services are increasingly supporting lots of parents with quite complex needs, so not necessarily just in that mild to moderate section. The biggest takeaway for us, which is brilliant to see in the report, is the recommendation for investment into grassroots. Some funders have done an amazing job at contributing during the COVID period. We do have some concerns that that might be a short-term view. Our biggest sort of recommendation would be that the VCS needs a long-term financial infrastructure in order to remain sustainable. Only in recent weeks, we've seen established organisations within our community really facing very real challenges in order to continue in operation. And that's just really sad, I think, at this time. I think that in conclusion, it would be really important for VCS services be able to articulate the value that they offer, and to be spoken about a bit more collaboratively, and to be recognised as a fundamental part of the integrated perinatal mental health pathway. Thanks a lot.
Thanks so much, Natalie, and thanks for being the voice of the sector today. And as you rightly pointed at the end, absolutely critical that you're part of the ecology of support that is extended to women during the perinatal mental health period. I want to conclude with the panellists. I want to turn now to Suella. Thank you so much for joining us today, and because it's because of Comic Relief's funding that this report and today's launch has been possible, for which we are all extremely grateful. Can I ask you, from Comic Relief's perspective, why was it important to fund this report? And what message would you give to the funding community at large? What do you see as next steps? In particular, for including and ensuring that support reaches all women, including women of colour and women from poorer backgrounds.
Thank you for that question, Luciana, and thank you for offering Comic Relief a seat at this panel. I hope I can contribute to what has already been said and highlight the importance of your work and why we are a funder of it. Comic Relief prides itself in funding mental health for over 25 years, which is not necessarily something that the public associates us with. Our mental health work is driven by the mission to get quality, accessible, and individualized mental health support without stigma or discrimination. And we also want to see others invest and take action, change policies, and remove legal barriers in support of people with mental health needs. That is why we also have been working with the Maternal Mental Health Alliance for 10 years as of this year. And this long-term approach and partnership has meant that we were able to set the building blocks for systems change. And among many other achievements of the Alliance over the years, the report is to be one of those building blocks. And it's been an extremely valuable and hugely learning journey for us as a funder to see how our ongoing support is leading organically, but also radically to a change that is wider than the organization's beneficiaries. That said, the pandemic has put an unprecedented strain on the nation's mental health. And it is sadly no surprise that, as the report proves, pregnant women and new moms have been worst affected. And it's clear the need is greater than ever, and with that, more support is needed urgently, because mom's mental health is everybody's mental health, and especially in a funding landscape first, where organizations unfortunately have to compete to gain the attention of funders for their causes, and secondly, in a particularly uncertain environment that we're finding or going to find ourselves in, economically uncertain environment that we're going to find ourselves in. A more strategic and sustainable approach is needed to the voluntary community sector support and services as part of the broader ecosystem. the original funding we provided was designed to try and address some of the gaps highlighted by the Maternal Mental Health Alliance research, and to make sure that community-based support is available that is complementary to and part of the statutory care pathway, so that women who are helped by specialist services are able to access more localized peer-led support to help them over the longer term. And by not recognizing the important role VCS services play as part of the jigsaw of support, opportunities for early help and intervention can be missed, which then result in greater demand for expensive specialist support later down the line. So the VCS need to be valued as equal partners and resourced to provide support to meet demand. We know that because of the huge demand, and to echo some of the things Natalie said as well, we know there's huge demand on NHS and statutory services. Many VCS organizations are supporting women in crisis who need more than they are able to provide, and are holding, quote unquote, holding them as best they can, which is risky and not a sustainable long-term strategy. And just to go back again on the point of strategic funding, I'd also like to add that it should ensure that support reaches all women. And as someone who comes from an ethnically minoritized community, I have seen and still see the implications of poor maternal mental health firsthand. And it's not just for the mom, but the entire families. And there is so much more to do and so much more to address, and recognizing the funding community as well as voluntary community sector in order to create a more inclusive and user-led service, as well as specific funding programs, ensuring that the support goes to the hardest to reach woman and the poorest woman. And I could go on about that, but I'm conscious of time, so I'm happy to pick that up offline with anybody who's interested. And I hope it answered the question. And thanks again.
Thank you so much, Suella. Really, really interesting and helpful to hear your specific insight, particularly as a funder that ensures that so many services are able to be provided in the absence of government funding. There's been a number of different questions, and Emily said at the beginning how we're going to respond to them all on the Maternal Mental Health Alliance website afterwards. Some are pretty detailed, some are broad, so I'm keen that we do that, and we will respond after this event. Just to say at this moment, quite a number of questions about a recording, and we will be circulating a recording of this event afterwards. Before I hand over, first of all, I'm just going to very quickly, I know Alan, you wanted to say something very quickly before I hand over to Sarah.
Muting myself. Yeah, if I'm allowed to, I just wanted to inject a little positive note onto this, if I may. As a preamble, we've clearly learnt in this pandemic that human well-being is more valuable to us than money, and that we must invest in prevention rather than waiting for disaster to strike. We also have learnt that children are our future, but we haven't quite grasped the idea that early childhood is even more important than school-age childhood, which of course is important for our future, but early childhood is really critical. And we haven't quite grasped as a society that if you want early childhood to go right, it's parents and families that we depend on to deliver a good early childhood as the foundation for a healthy next generation and a healthy society. But the one great fact about this challenge that we're talking about is that we know what to do. And we have in this country, in these four nations of ours, the potential for the greatest infrastructure in our statutory and our third sector services in the world to deliver a fantastic future for our children and a fantastic present for our families. So let's value mental well-being as well as physical well-being. Let's value the next generation, and let's do something utterly, utterly fantastic for them that we have never done before. This is the moment to grasp it.
Thank you, Alan, for those very positive, uplifting remarks, which draw this section with our panelists to a conclusion. If I can thank Janet and Suella, Natalie, Alan, and Melita, who joined us on the line, for all of your contributions. It's been really helpful to hear your perspectives. It's now my pleasure and privilege to hand over to Sarah Hughes, who's the CEO of the Centre for Mental Health.
Well, thank you, Luciana, and thank you to that panel. I felt like I could have broken out into song there, Alan, for that rallying cry, so thank you very much. I think, you know, we're very privileged at the Centre to do this work on behalf of the mental health and in partnership with the Maternal Mental Health Alliance. And I think before I say anything about that, I think it's important to acknowledge that the last couple of weeks have been incredibly difficult for women's mental health. And I think it's fair to say that the kind of dialogue that we're all seeing and part of externally can be quite toxic. And so in many ways, I want to start what I want to say by acknowledging that, by sending love and solidarity to women out there. We have had many struggles, and what we're hearing now isn't new news. And so I'm afraid that we must galvanize all the energy we have to bear what we're seeing at the moment and look after each other. So with that said, I think, look, why is this work important? I mean, I think the panel and all of the speakers so far have given you some clarity about why this is important. I mean, effectively, I think, I can't remember who said it. I think it's Suella who said it, you know, children's mental health, mother's mental health is everybody's mental health. And I think that will stay in my mind as a kind of really helpful way of thinking about this. And look, I'm somebody who experienced the most profound postnatal depression in 2010 after the birth of my first child. And I've written about that and posted it today so people can revisit my story. And I know for sure that a CPN saved my life. There is absolutely no doubt about it. But when I cast my mind to today and I think about what would it have been like if I had had my baby in 2020? And whilst I can't imagine it, because I think it's so beyond my comprehension, I know intrinsically, deeply, that it would have been incredibly isolating, frightening, life-threatening for me. I was suicidal when I was just about to receive treatment. So I know without that support that I would have been at great risk. Not seeing my family, not being able to talk to my mum, not being able to sit there with my brothers and extended family just to kind of be together and to just be, you know, that kind of supportive network. Of course, supportive networks, not everybody, not every woman has those, but certainly the pandemic would have stripped away and dismantled any of that support we might have been able to access. But we do know that pre-pandemic, that much progress had been made, that we were seeing perinatal mental health teams being rolled out. We were getting a level of understanding about perinatal mental health across the workforce in a way that we hadn't done before. We can't let the pandemic dismantle that. The pandemic has dismantled so very much of what we hold dear, what's important to both us as individuals in terms of accessing services and so on. So we really must take the learning, the opportunities that we've had over the year to really understand what women need, to really make sure that we don't go hell for leather into digital support, which could potentially exclude so many. So I think for us, the challenge is to realise these recommendations, to use our networks, all of you on this Zoom room and others, to really kind of maximise the opportunity, amplify the recommendations, talk to your MP, talk to your local mental health trust, engage them in conversations about what services are being provided, how are women from racialised communities and those excluded from help usually are getting the help that they need when they need it. So I guess, you know, I want to join Alan with that kind of rallying cry. So much is good, so much is known about what we can do. The fact is we need to get on and do it. The fact is we need investment, and we need our government to really recognise that maternal mental health really does impact people for a lifetime. it's not just the first few months of life. This is about your life chances. This is about your life trajectory. And we know that we can turn the ship around if we implement the things that we know work. So enough from me. I think you've heard enough from the speakers about why this report is important, what we think needs to happen. But we're going to leave you with a film with extraordinary voices from women with lived experience. And while you're listening to this, I want you to hold in mind that it's incredibly difficult for women to speak their truth. And so I want you to hear what they're saying with open heart and minds, and as a way of motivating what you do next. So over to the film. Thank you.
I know the parents that we support have found that the lack of contact from people has been really, really hard. So lack of contact with family, with friends, with wider support networks, baby groups and professionals, not having those face-to-face appointments with professionals particularly, and then also the challenges that you get from communication on the phone that you don't have but face-to-face.
From my own experience, to provide comprehensive care would include better communication between GPs, midwives, health visitors, doctors, anybody who's involved with the mother and child, that they sit together, review the woman's needs, make a plan and ensure a coherent way forward.
One of the things that helped my wife and I through the traumas of postpartum psychosis and postnatal depression was the support we received from the specialists, particularly the community psychiatric nurse. And I think about times now with COVID and how some mothers won't be able to get access to that support, and it scares you because you're thinking sometimes the only real support you can have and really need during that tough time is people to be there for you, and COVID has really taken that away.
Please keep investing in maternal mental health care, whether this is for care for women with a community mental health team, mother and baby unit, or supporting the third sector to provide peer support and vital information. All of these things are important in COVID and beyond. Please don't forget about maternal mental health.
Trying to conceive through a fertility treatment during a global pandemic as an LGBT+ person has been really difficult for myself, my wife and my family. It has also been difficult for tens of thousands of other people going through fertility treatment during the pandemic, and really detrimental for their mental health to not have their partners attend scans and appointments with them or have access to resources.
The pandemic has left countless vulnerable women without support. Reduced face-to-face contact means non-verbal communication is being missed, slowing down early intervention and leaving these women feeling even more alone. My message to national decision makers: please do not let this become the new norm. We've come so far. Don't let the pandemic reverse that progress and help us to continue our fight to reduce the impact of perinatal mental health.
Well, thank you so much to those that have shared their experience with us today via the videos. I don't think there are any voices that can be more powerful than yours and what we've heard today. And it's because of your experience that we have all joined on this webinar and focus on the report. If I can thank the panelists who have shared their expertise with us today, and really to thank all the hundreds of people who have joined us on this session. We really, really, really appreciate your time that you have given up to be part of this event. This report is an opportunity for new and expectant mums' voices to be heard and to try and ensure that support is in place for all women and families, no matter where you live or your background. We really hope that you will take something of what you've heard today beyond this Zoom and post something of the report on your channels, again using the hashtag maternal pandemic. And please do all that you can to ensure that this report is shared far and wide, and in particular engages those decision makers across our 4 nations who can actually help create change to hear these messages. So please tweet your MP, send a copy to your local representative, to your mental health trust. Do please share it far and wide. Thank you all so much again. It's been great. As I said, been joined by hundreds of people. We look forward to sharing the recording of this event afterwards, and we look forward to working with you all to really make a difference to women for the perinatal mental health period. Thank you.